Hey everyone! My name is Karen and I'm an NBE certified POCUS enthusiast. Today's screencast will cover the fundamentals of lung ultrasound acquisition. Gaining experience in lung ultrasound is invaluable to anyone who cares for acutely ill patients. I will be following the screencast with a deep dive into lung ultrasound interpretation. Let's get started. It is important to appreciate a few key principles. Firstly, lung ultrasound has a higher sensitivity and specificity than chest X-ray for the detection of several pulmonary pathologies, including pneumothorax, consolidations, interstitial syndrome, and pleural effusions. Furthermore, it can be rapidly deployed at the bedside and gives real-time information that can be acted on. Thus, it can help you rapidly identify critical pathologies in a patient with respiratory distress. Remember that ultrasound transmits and receives sound waves to generate images. However, sound waves are scattered by air, which normal lung is full of. Thus, lung ultrasound is based on the interpretation of artifacts that are generated when air scatters ultrasound sound waves. Therefore, when you're choosing an ultrasound preset, pick either the lung or the abdominal preset. Both of these presets will turn off the artifact minimization algorithms that ultrasound machines regularly use. The lung preset is particularly useful to detect lung sliding and quantify B-lines. On the other hand, the abdominal preset is especially helpful in detecting consolidations and effusions. I personally often use the abdominal preset for most of my lung ultrasound scanning. Finally, there is no right or wrong probe to use when performing lung ultrasound, and you may encounter different arguments for using each. As a review, recall that the linear probe has high resolution due to its high frequency. Thus, it produces detailed, clear images, particularly for small objects. However, it is limited to a depth of approximately 6 to 7 centimeters. Therefore, the linear probe is ideal to assess for lung sliding, but offers limited utility for comprehensive lung ultrasound. The curvilinear probe has a lower resolution and produces less detailed images. However, it can assess deep structures up to 23 centimeters or more. This allows it to perform comprehensive lung ultrasound, where you need a depth of approximately 10 to 12 centimeters or more to diagnose B-lines, consolidations, effusions, etc. Furthermore, its large footprint means that you can assess multiple rib spaces at once. Finally, the phased array probe has similar features to the curvilinear probe, but a much smaller footprint, which allows it to fit within the rib spaces. I find the phased array probe to be the best all-in-one probe, and I personally start with this probe using the abdominal preset to perform lung ultrasound. If I want to better assess the pleural line, I will switch to the linear probe. On the other hand, if I want to assess multiple rib spaces or have a wider view, I will switch to the curvilinear probe. Again, there is no right or wrong choice, just know the pros and cons of each probe that you're using. Similarly, there are many different lung ultrasound acquisition protocols reported in the literature. These range from a rapid 2-zone protocol to the thorough yet more labor-intensive 16-zone protocols. Probably the most famous protocol is the Blue protocol, as outlined by Dr. Daniel Lichtenstein. This 12-zone protocol has recently been recommended by the 2025 ESICM Consensus on Quantitative Lung Ultrasound. Each point evaluates a different part of the lung. I often toggle between this and an abridged 8-zone protocol when scanning patients. In this protocol, each side of the chest is divided into 6 scanning points. On the right side of the chest, R1 and R2 assess the anterior part of the lung. R3 and R4 assess the lateral part of the lung, while R5 and R6 interrogate the posterior part of the lung. Whatever protocol you choose, please ensure that you are consistently scanning each point for every patient. Furthermore, ensure that you accurately label your images to communicate your findings with colleagues. It can be helpful for you and your group to come to a consensus on which protocol to use, so that you're speaking the same language. For the rest of this screencast, we will be talking about how to perform comprehensive lung ultrasound using this 12-zone protocol. I will also be describing the use of the abdominal preset on the phased array probe. R will refer to points on the right side of the chest, while L will refer to points on the left side of the chest. To obtain R1, place the probe at the midclavicular line at the second intercostal space. Start with a depth of approximately 10 to 15 centimeters. Your probe marker should be facing the patient's head. Slide so that you are in the rib space rather than on the rib itself. You should see the following image generated. At the very near field of the screen is the patient's chest wall. The pleural line is the hyperechoic shimmering line just below the chest wall. It is flanked by two rib shadows. The most important artifact to detect when scanning the anterior lung fields are A lines. The more A lines you see on the screen, the more perpendicular you are to lung tissue. Thus, rock and fan your probe to bring out as many A lines as possible. Importantly, you must either see a predominantly A line or predominantly B line pattern in the anterior lung fields. Even if you have a predominantly B line pattern, you can often see A lines peek through as the B lines move in and out of view. This tells you that you are perpendicular to lung tissue. If you are not perpendicular to the lung, you will attain a non-A, non-B line pattern. This is non-diagnostic and gives you no information about the lung you are scanning. Next time you're scanning the anterior lung fields, practice rocking and fanning, and you will be surprised at how many A lines you're able to detect. R2 is obtained in a similar manner to R1, but it is simply slightly lower down on the chest. From the R1 position, slide down to the fourth intercostal space in order to obtain R2. In normal lung, you will see the exact same view as you did with R1, and the findings will be interpreted similarly. Next, interrogate the lateral lung fields. To obtain R3, place your probe at the mid-axillary line at the third or fourth intercostal space. Your probe marker remains pointing at the patient's head. Like the anterior lung fields, rock and fan until you bring out A lines, which demonstrates that you are perpendicular to the lung. R4 is obtained by sliding inferiorly until you are approximately at the seventh intercostal space. It will be around the same lateral plane as the xiphoid process. This view displays the interface between the lung, diaphragm, and the intra-abdominal structures. On the right side, you will see the liver. You can often also see the spine just posterior to the liver. In L4, you'll see the spleen instead of the liver. I often refer to this view as the modified fast view. Your probe is essentially superior on the chest wall compared to where it would be for a fast exam. The key structure to identify in R4 and L4 is the diaphragm. The diaphragm appears very hyperechoic because it is surrounded by connective tissue layers that strongly reflect ultrasound waves. Anything above the diaphragm will be intrathoracic, and anything below the diaphragm will be intra-abdominal. These compartments are very important to distinguish so that you don't inadvertently mistake abdominal free fluid for a pleural effusion. Finally, we move to the posterior lung fields, R5 and R6. These are often challenging to obtain in supine patients, but keep practicing. From the R3 position, slide posteriorly beyond the posterior axillary line. This will give you R5. There are no real landmarks for R5, so you must be very accurate when labeling your clips. In supine or semi-recumbent patients, it is very common to see B lines at the posterior lung fields. This does not always reflect pathology. Similarly, R6 is obtained by sliding posteriorly from the R4 position. You should see the liver on the far right of the screen, and you may sometimes also see the IVC. The left-sided scanning landmarks are mirror images to the right-sided scanning points. Thus, once you've mastered scanning one side of the chest, you can apply the exact same techniques to the other side of the chest. After watching this video, the most important thing you can do is apply these concepts in real life by practicing lung ultrasound on patients. And there you have it, the fundamentals of lung ultrasound acquisition. Stay tuned for future videos on lung ultrasound interpretation. Thank you for listening, and see you next time.